And we'll have the presentations, the first country experience from Kyrgyzstan, so which will be presented by Bakyt Myrzaliev. Bakyt is a medical doctor with a PhD in TB diagnosis and is representing KNCV Tuberculosis Foundation in Kyrgyzstan. He led the scale-up of the BPAL regimen introduction in Kyrgyzstan. He directed the USAID TB care and Challenge TB projects, introduction of the new drugs and shorter treatment regimen. And as the deputy director of the National Center for Physiology, he guided national TB control effort, and Dr. Bakyt has authored numerous publications, contributed to national TB programs and guidelines, and is an active member of the professional groups, including Union LabCap and the Euro TB Coalition. So Bakyt will share the experience of Kyrgyzstan with us. Bakyt, the floor is yours. You can project your slides.
Thank you very much, Mansa, for such a great introduction. Thank you very much. And let me, on behalf of our team from Kyrgyz Republic, KNCV team in Kyrgyz Republic, present results of our work in the last half of year in collaboration with the National Tuberculosis Program. How we use the benchmarking and planning tool developed by KNCV Global to improve TB care for children and adolescents in Kyrgyz Republic. The next slide, it's about country information. Kyrgyzstan is located in between China, Kazakhstan, Uzbekistan, and Tajikistan. In WHO region, it's a European region. By World Bank income level, we are low middle income country. Located Kyrgyzstan in Central Asia with population 7.2 million by a calculation of 2024. And also you can see on screen our epidemiology data about every estimation. Every year it's around more than 9,000 TB cases have to be detected in Kyrgyzstan. But in fact, we have detected around 4,000 TB cases in Kyrgyz Republic. The next slide is about background objective. TB in children and adolescents are remaining underdetected globally. WHO recommends integrated child-friendly TB services, and objective of a benchmarking and planning tool of self-assessment. Access alignment with WHO recommendation, identify systematic gaps, support evidence-based planning with stakeholders. And for now, we are using the benchmarking tool in Kyrgyz Republic as self-assessment progress. We organize a meeting to translate. At the beginning, we translate all these guidelines, methodology, and the Excel sheet to Russian language. National self-assessment conducted with the NTP team under the Ministry of Health, pediatric TB expert, and under the KNCV facilitation. Validation on the multi-stakeholders workshop with the number of partners. Around 38 people was participate. More than 15 partners was identified. Focus on policy, service delivery data, and integration. Key achievement, policy and guidelines. National pediatric TB guidelines aligned with WHO guidelines. Child-friendly TB regimens available nationwide. Preventive TB treatment implemented for eligible child contacts. Pediatrician regularly trained on TB diagnosis and management. New molecular test available for presumptive pediatric TB test, child-appropriate sample collection techniques used, TB screening mostly integrated into pediatric and primary healthcare level services, improved collaboration between TB specialists and pediatricians. First national application on benchmarking tool and planning for children and adolescents was adopted and tested in Kyrgyzstan. Structured identification of gaps and priorities. With all partners, we sit together, discuss all these gaps, and countries have ownership of identified gaps and priorities. Evidence-based dialogue with partners. All available partners who participate on that meeting make sense that this kind of gaps we have on the country level. Action-oriented outcomes linked to existing initiatives. Which kind of gaps and challenges was identified on that meeting? Scope of the further integration of TB service at PHC level. Centralized referral system delays diagnosis. Pediatricians have limited authority to initiate TB treatment and care. Weak age disaggregated data, especially for adolescents. We still have a little bit differences with the recording and reporting system with recommended WHO guidelines. Limited engagement of private sector. Fragmented, not exactly fragmented, but partially integrated referral system and feedback mechanisms. In total, we mapped more than 15 stakeholders, providers across the national, regional, and facility levels, covering TB, primary healthcare level, social, and private sector. National TB program, NTP, provide leadership and coordination, monitoring of pediatric TB policy and guidelines, clinical care, expert consultation, pediatric TB management. Primary healthcare level, FMCs, responsible for early detection, referral, ambulatory care, and follow-up treatment. Social services and psychological support, child protection and social assistance. Private healthcare providers, first contact care and referral of presumptive TB cases. On geographical coverage, we cover national level, Bishkek City, Chuy, and Jalabad Oblast. It is biggest size of population in these levels. Coordination at added value. Direct coordination with NTP, leadership, and monitoring units. Established clinical collaboration with National Tuberculosis Program pediatricians and TB experts. Functional referral pathway between PHC level and TB services. Clear scope for further integration of TB, PHC, and social support services, particularly for children and adolescents. Role of stakeholders. NTP, as we learn, was responsible for leadership and coordination. Other partners and donors like UNDP, Global Fund, was responsible for medicines, provide diagnostic. Also, another partners from World Health System also provide support for nutrition. WHO office in Kyrgyzstan and other partners like Cure TB Project 2 provide technical guidelines and capacity building. PHC facility screening was responsible for contact investigation and treatment support. Civil, also we have some value at CPHC level. We not forget about community society organizations, which provide psychosocial support and support for adherence to treatment. It's International Red Crescent Society and Densoluk Nuru organizations, and a few other organizations. And as KNCV facilitation analytic planning knowledge translation. Stakeholder workshop from gaps to action. 38 participants from health, social protection, and community society organizations participate on this workshop. And we come to consensus of priority action, decentralization of TB care and making decision to PHC. SOP for referral and screening have to be developed and trained for PHC also and other organizations, including private providers. Pediatric TB focal points also have to be identified because now it is not exactly responsible. It's at the national level. Multi-sectoral collaboration is need to be improved. Additional gaps identified which is requiring phased attention. A limited integration of TB services into routine PHC workflow. Insufficient coordination with social services for vulnerable children. Gaps in preventive treatment, initiation and completion among children and adolescents. A limited involvement of private sector and non-TB providers. Need for stronger data use and subnational level for detection making. Okay, guys, somebody speaking. Immediate public health impact, TB outbreak detected. During our workshop, our NTP manager also reported that in one of the religion schools was identified more than 30 children with possible TB, presumptive TB. And National Tuberculosis Program provides rapid coordination and response and start nationwide screening among all religion schools for screening for tuberculosis. Facility assessment and healthcare workers interview. TB screening integration, which kind of opportunities and gaps? Pediatric and where it can be strengthened in pediatric, general outpatient and family medicine services. Same as mother and child health and HIV clinics. Private clinics as first contact entry points. Key gaps to address centralized referral limits, PHC actions. Weak PHC need coordination and support on tuberculosis. High workload, training gaps, and fragmented data. Limited private sector engagement and stigma. Which kind of priorities was and next steps was identified? Empower primary health care facilities through policy, training, monitoring, and SOPs. Strength coordination and continuous training and mentorship. Scale up integrated digital referral and reporting. Which kind of lessons? Benchmarking and planning tool is practical and action-oriented, not theoretical. Facilities constructive dialogue across sector. Makes invisible gaps visible, especially data and integration. Strengthens national ownership and accountability. Helps translate WH lines into country-specific actions. Which kind of national structured self-assessment of pediatric TB was conducted? Strong stakeholder on the institutionalized for follow-up.
Bakyt, we lost you.
Here, you see me? Can you hear me?
Yeah, there is some breakdown with your internet.
Okay. Okay, it's
Now it's better. You can
connection.
continue.
Okay, thank you. Benchmarking and planning tool supports evidence-based planning. Integration into PHC is critical to pediatric TB. Stakeholder engagement drives real-world impact. Kyrgyzstan experience showed tools value beyond assessment, and sustained technical and financial support is essential. Thank you very much for attention. These all participants of our workshop and other participants which was not on the picture also have information and provide inputs to this review, not exactly review, assessment, and it's some kind of connection in between partners, because many years we not have this kind of workshops when all partners sit together with Global Fund, Cure TB, and other partners who available on the country level, even State Medical Academy and TB practitioners, healthcare providers from PHC and other facilities. And we was happy to sit together, discuss all these gaps and provide inputs and agree for the next steps. Over.
Yeah, okay, Bakyt, thank you very much for the presentation. Just to mention again, if you have any question, please put it on the Q&A. So, but now for Kyrgyzstan, we still have time and we can take one question. So if you have any question, maybe you can raise your hand and ask Bakyt that question. Okay, Christine, Bakyt, there's a question for you.
Yes, please.
Thanks everyone. Thanks Bakyt for the presentation. So you mentioned actually that during the workshop you got to know about this outbreak in the school. I was wondering, would you have heard about this if you would not be in this workshop? You think?
Sorry, can you repeat the question?
So you told us that you got informed about this outbreak in the schools during the workshop. So I was wondering, if there had not been the workshop, would you have known about this outbreak?
Our NTP manager was visited that facility. At first of all, the healthcare practitioner from PHC level who identified these cases also reported to NTP, and NTP during the workshop, our NTP manager come for our meeting and explain that this kind of outbreak happened, and he just back from that facility because a few weeks he spent there to screen all these children, more than 1,000 children in these religion schools, and all of them was screened by a mobile X-ray machine with artificial intelligence for active tuberculosis. And later he also sent people with a skin test to provide screening for tuberculosis infection among these people. And same time he also start some active screening in all other religious schools related to especially for tuberculosis. And especially we learn this information from NTP manager, and NTP manager coordinate all these activities and report to Ministry of Health and higher level.
Okay, thanks. You actually also answered one of my other questions about how the screening was done, and maybe one more question. So we know about the outcomes of this one school, but in general, sort of how much more do we know about infection level among these children in the schools? What was the level of positivity for TB?
Especially as was reported, it's a little bit sensitive information, and at that schools was identified more than 30 people with active tuberculosis, and for now we have also a request from NTP manager about support about to provide further investigation about epidemiological survey and request additional reagents for providing full genome sequencing among these all these children, and to identify the pathway of this tuberculosis infection among other facilities where the people also identified. And just at the last week in one of the city schools, it's not religious schools, just usual schools, also for 7 and 8 classes was identified one teacher with active tuberculosis, and it's provided also a lot of screening and activities to identify people, children with TB infection there. And the level for now is not exactly clear. It's data is collected, but also we have to report about it. Maybe it will be prepare some kind of paper about this case, because it's not usual case for Kyrgyzstan.
Good, thanks, Bakyt. And I do hope we really can support the sequencing there as well. Thanks.
Thank you very much. And thank you very much for Christine and our KNCV headquarters who provide support to procure this extra reagents for Kyrgyzstan to provide this epidemiological survey among this, because it also was a request not only NTP, also request of the Ministry of Health, and NTP manager directly reported about all this about situation to the Ministry of Health.
So Bakyt, thank you very much. I have to stop you. We are going against time. Yeah, and Christine, maybe just also to add one thing, because on the agreed actions during the workshop also was a recommendations to conduct screening in all of the madrasas that are in the country, and the NTP will take over that. Okay, then we have to move to the next presentations, and the next presentation is from Chad. So Chad will also share their country experience and the use of the benchmarking tools on what's their achievements, the gap identified, and what are the action points. So, and this will be presented by Adberramane Abdelrahim Barka, who holds a master's degree in public health and is a PhD candidate in project management. He has over 14 years of experience in TB HIV program management, monitoring and evaluation, and epidemiological analysis of tuberculosis. Adberramane, you can share your screen. So this presentation will be in French. So you can turn up the translations in English or other language.
Ok, merci beaucoup à tous. Merci à KNCV pour cette opportunité du projet sur l'auto-évaluation de l'outil d'analyse comparative et de planification de la prise en charge de la tuberculose chez les enfants et adolescents. Comme vous le savez, le Tchad, c'est un pays francophone. Avec beaucoup de défis, on a 1 284 000 km² de couverture, et la présentation se fait comme ce plan. Comme je l'avais dit ici, à droite, vous allez voir la carte du Tchad, qui est un pays de l'Afrique centrale, limité par 6 pays, la Libye, le Soudan, la République centrafricaine, le Nigeria, le Cameroun et le Niger. Et on a 5 pays qui connaissent des crises actuellement. Comme vous le savez, la crise du Soudan, de la République centrafricaine et du Nigeria avec les Boko Haram, qui fait qu'aujourd'hui, le Tchad accueille sur son territoire de plus de 1 million de cas de réfugiés, qui a un impact sur le système sanitaire du pays. OK, la population tchadienne est estimée à 19 millions d'habitants et l'incidence estimée selon le dernier rapport 2025 de l'OMS est de 118 cas pour 100 000 habitants rapportés à la population. Ça nous fait 24 000 cas attendus. Et notre système de surveillance a pu notifier 16 948 cas avec un gap des cas non détectés de 29%. Par rapport aux enfants, on attend 2800 enfants et sur les 2800 enfants, il y a 1165 qui sont notifiés. Soit le gap est très important chez les enfants, qui est autour de 58% des enfants que le système n'arrive pas à les capter. L'incidence de la co-infection TB-VIH est de 11 cas pour 100 000 habitants, qui nous fait 2300 cas à notifier. Et pour la tuberculose multirésistance, on est à 2 cas pour 100 000 habitants. Rapporté à la population, ça nous fait 400 cas à notifier. Voici, vu l'étendue du territoire, on a un taux de couverture en CDT, cela veut dire en points d'offres de la prise en charge de la tuberculose, estimé à 155 cas, 155 000 habitants pour un CDT. Et là, pour la distance, dans certaines zones, les gens parcourent presque 100 km à 150 km pour avoir accès aux services de la tuberculose. Et les sites de prise en charge TBMR est de 28 sites avec 54 appareils hygiène experte. Diapo. Pour les objectifs de l'évaluation de l'outil, c'est d'évaluer l'état des mises en œuvre et recommandations mondiales sur la tuberculose de l'enfant et adolescent, d'évaluer l'intégration des dépistages de la tuberculose dans le système de santé. Et comme objectif spécifique, on a l'évaluation de la mise en œuvre des politiques relatives à la tuberculose chez l'enfant et les adolescents, la compréhension et la perception de responsables du programme tuberculose à tous les niveaux et les prestataires des soins de santé et les partenaires à l'utilité de l'outil, l'identification et des difficultés rencontrées lors de la mise en œuvre de l'outil et l'élaboration des recommandations, la documentation des meilleures pratiques issues des mises en œuvre réussies et l'évaluation de l'amélioration des critères de référence ainsi que l'élaboration d'un plan d'amélioration. La méthodologie qui a été utilisée pour évaluer l'outil sur la planification de la tuberculose. La méthodologie est utilisée. Au départ, il y a eu la prise de contact avec l'équipe du programme national de lutte contre la tuberculose et les consultants internationaux, le partage des documents, surtout sur le protocole générique et puis l'outil Excel. Le recrutement des 3 consultants nationaux, il y a eu une réunion en ligne entre les consultants sur le briefing par rapport aux différents outils, les remplissages et certaines questions qui ont été posées. Ainsi, la revue documentaire du programme par rapport aux dernières recommandations, comment ça se fait la prise en charge de la tuberculose. Et après cela fut le remplissage de l'outil benchmark et planification. Après cela, il y a eu la mission de terrain dans 3 sites pour le remplissage de l'outil. En août, il y a eu l'atelier des parties prenantes qui a regroupé des personnes qui sont venues de l'intérieur du pays, de 5 provinces, les partenaires techniques et financiers de l'OMS, les pédiatres, ainsi que les sites confessionnels et les sites étatiques. Après cela, il y a eu l'élaboration du rapport final ainsi que la publication scientifique. Les établissements visités, pour le remplissage de l'outil. Il y a le centre hospitalier universitaire de la mère et de l'enfant, qui est au niveau 3e niveau. C'est un hôpital national spécialisé dans la prise en charge de la mère et de l'enfant, qui se trouve au niveau de la capitale N'Djamena. Et c'est un centre urbain et cet hôpital est étatique. Le second établissement à visiter, c'est un centre santé primaire, cela veut dire du bas niveau, c'est un centre santé périphérique et qui est à N'Djamena, se trouve au-dessus à N'Djamena et c'est un centre confessionnel. Et le troisième, c'est un hôpital provincial de 2e degré qui est à 150 km. OK. Après les établissements de santé visités, ça nous a permis de faire la cartographie des intervenants en matière de lutte contre la tuberculose en général et la tuberculose chez l'enfant en particulier. On a l'État à travers le ministère de la Santé qui intervient dans l'offre des soins ainsi que le financement de lutte contre la tuberculose à travers le recrutement des personnels, la construction des infrastructures, l'équipement laboratoire ainsi que l'acquisition des médicaments. Le programme reçoit une subvention pour l'acquisition des médicaments et autres à hauteur de presque $1 million chaque année. Les principaux domaines, c'est la couverture, c'est au niveau national sur toute l'étendue du territoire. Et le projet est en continu, car le programme national fait parmi les programmes prioritaires au niveau du Tchad. On a le Global Fund à travers le financement de lutte contre la tuberculose qui intervient dans l'acquisition des médicaments, les réactifs et les consommables, ainsi que le financement du renforcement des capacités et la reproduction de certains documents. Et là aussi, la couverture sur toute l'étendue du territoire. Et on est au GC7 parce que le cycle a commencé, le Tchad a un retard d'1 année. Et là, le GC7 a commencé en 2025 et qui prend fin en 2027. Et à travers Expertise France, le Tchad a bénéficié d'un projet qu'on appelle DEPIS V chez les enfants tuberculeux et VIH. Et comme principaux domaines d'intervention, on a l'amélioration des dépistages précoces de la prise en charge de la tuberculose, 0,5 ans exposé au VIH et atteint de tuberculose. Et là, ce projet, c'est dans 2 provinces, qui est à savoir N'Djamena, qui est la capitale du Tchad, et la province du Bol, au niveau du lac Tchad. La province qui fait frontière avec le Nigeria, le Niger et le Cameroun, avec beaucoup de défis sécuritaires. Et enfin, on a l'OMS à travers la mobilisation des assistances techniques et les campagnes de dépistage actives à travers le camion mobile. Et là, ça s'est fait en N'Djamena et le partenariat couvre 2025 à 2028. Voici les normes et critères qui sont évalués à travers. Et là, il faut se dire que le programme à travers le Fonds mondial, a révisé son guide, le guide de prise en charge de la tuberculose de l'enfant et adolescent en décembre 2024 à travers une consultante internationale mobilisée par le Fonds mondial. Et là, le guide a été validé selon les dernières recommandations du Fonds mondial et même la formulation les schémas courts de 4 mois chez les enfants qui ne sont pas grabataires, ainsi que les régimes courts sur le traitement préventif ont été pris en compte dans ces guides. Et là, parmi les normes ici évaluées, on a des normes qui ne sont pas complètement respectées à travers la mise en place du groupe consultatif national sur la tuberculose de l'enfant et l'adolescent. Et là, c'était même une recommandation pour la consultante, ainsi qu'une assistance technique efficace pour la prise en charge de la tuberculose chez l'enfant et l'adolescent. Et après cela, on a les non respectés qui sont au nombre, les non respectés qui sont au nombre les partiellement respectés qui sont au nombre de 12 et les autres sont tous respectés. Pour l'évaluation des formations sanitaires, les principaux constats sont les suivants. On a les services de lutte contre la tuberculose sont disponibles dans toutes les structures sanitaires disposant d'un laboratoire, mais l'intégration systématique de la tuberculose de l'enfant reste incomplète. Cela veut dire reste faible. Les prestataires ne pensent pas, ne recherchent pas la tuberculose. La capacité des diagnostics pédiatriques sont hétérogènes, avec beaucoup de lacunes qui ont été remarquées au niveau des soins de santé primaires. Et là, c'est pour cette raison qu'on a revu le guide à travers pour intégrer les deux algorithmes que vous voyez, l'algorithme A et B de l'OMS qui permettrait au niveau plus bas aussi de diagnostiquer la tuberculose à travers la notion de contact. La recherche systématique des cas contacts et la mise sous traitement préventif des TPT sont intégrés dans la politique nationale, mais faiblement opérationnelles. Les formes galaniques adaptées aux enfants sont globalement disponibles avec des défis liés à la continuité d'approvisionnement et l'utilisation correcte. Et les circuits de référence existent, mais insuffisamment formalisés. Outils. Ici, action prioritaire qu'on a pu identifier, c'est la mobilisation immédiate des ressources pour renforcer le diagnostic pédiatrique GINESPER, cartouche, kit et prélèvement des selles et la formulation pédiatrique. Comme vous le savez, avec la conjoncture actuelle, beaucoup des activités en lien avec la tuberculose de l'enfant ont été coupées avec les fonds mondiaux. Et là, on est à la recherche des financements pour augmenter les cartouches GINESPER, le prélèvement à travers les selles et les transports d'échantillons. La mise en place rapide du groupe technique sur la tuberculose pédiatrique, la diffusion des algorithmes simplifiés de la tuberculose pédiatrique, surtout la reproduction et la diffusion des deux algorithmes A et B selon la formation sanitaire qui permettra d'augmenter le diagnostic de la tuberculose chez les enfants, le renforcement des capacités des prestataires sur l'investigation des contacts, les diagnostics de la tuberculose pédiatrique, ainsi que les traitements préventifs de la tuberculose et le renforcement de l'approche communautaire par l'implication des AEC, surtout sur l'identification des signes de la tuberculose chez l'enfant et l'adolescent, ainsi que le suivi, les TD ou les traitements directement observés chez l'enfant aussi. Voici quelques indicateurs clés à court terme pour la proportion des enfants âgés de 0-14 ans parmi les patients tuberculeux notifiés par les programmes. Ça tourne autour de 7%. Ça tourne autour de 7% sur les 3 dernières années. Et par rapport aux enfants en contact dépistés et mis sous traitement, selon le système de surveillance, cela veut dire les enfants qui sont vus par un personnel de santé et investigués et screenés pour la TB, on a exclu une tuberculose évolutive et ils ont commencé un traitement préventif. Ils font 90%, 83% en 2023 et 93% en 2024. Mais si vous prenez le dernier rapport de l'OMS, par rapport à l'indicateur de contacts familiaux qui sont mis sous traitement préventif, on est passé de 3,2% en 2022 à 6,8% en 2024. Et sur le nombre de structures ayant reçu l'outil et bénéficié des formations, c'est 20 CDT qui ont reçu la formation sur l'outil Bishmak. Et ce qu'il faut noter, il y a certains qui ont déjà, à leur retour, ils ont fait la restitution à leur équipe pour l'utilisation de cet outil afin de les guider à diagnostiquer la tuberculose. Mais voici un dia qu'on voulait vous présenter. Et là, vous voyez chez les enfants 0-4 ans, ce qui est en rouge, ça représente les cas que le système n'a pas pu détecter. Et en vert, c'est les patients, les enfants 0-4 ans qui ont été mis sous traitement. Chez les enfants 0-4 ans, on a des cas manquants à l'ordre de 62%. Chez les 5-14 ans, on est à l'ordre de 54% et chez les adultes, on a un gap de 26%. Et là, on peut conclure que nous, les adultes, on se traite et on laisse à côté les enfants 0-4 ans. Là, il faut vraiment faire quelque chose pour sauver la vie de ces enfants 0-4 ans. Comme recommandation aux partenaires et aux décideurs, il faut un appui financier ciblé pour les diagnostics pédiatriques, le soutien technique pour la formation, le mentorat et la mise à jour des documents normatifs. Le message clé, l'outil BP a permis d'identifier clairement les outils, les goulots d'étranglement et d'orienter des actions immédiates pour améliorer la détection, le traitement et la prévention de la tuberculose chez l'enfant et adolescent au Tchad. Sur ce, je vous dis merci beaucoup.
Okay, Abdelrahman, thank you very much for the presentations. I think that now we don't have time for questions, so but if you have any question for Abdelrahman, just put it in the chat or you wait for the Q&A, you can and you can ask your questions. So we'll move to the next presentation. So and the next presentation from MSF. So and the presentation will share the experience on treatment decision algorithm. So experience from MSF Tactics project, which is test, avoid, treat TB in children. So and this will be presented by Olga Kondakova. So Olga is a medical doctor focusing on infectious disease and tropical medicine with over 10 years of MSF experience in both clinical work and health program management. She currently works as a mobile implementation officer for the MSF Tactic project, which supports the implementations of new pediatric recommendations across MSF projects and provides support to activities in Guinea-Conakry, Somalia, the Central African Republic, and Myanmar. Olga, you can share your screen and continue with your presentation.
Yes, hello everyone. Thanks. I shared the screen. I hope you can see it.
Yes, we can see it.
Okay, that's great. Hello everyone again. Thanks for invitation. And on behalf of the MSF Tactic team, I would like to share the experience of Doctors Without Borders Tactic project on the implementation of WHO TB treatment decision algorithms. Before start, just a brief overview. What is the TB treatment decision algorithms and why it is needed? Probably you know better than me that this is a new tool which was recently recommended by WHO, data-driven tool for quick and easy and very structured TB treatment decision for children under 10 with symptoms of pulmonary TB. What is the strong point of this tool? That it's analyzed different factors like age of the child, comorbidities like HIV, for example, or undernutrition, especially severe acute malnutrition, also duration of symptoms, contact with TB, and results, if available, of diagnostic tests like GeneXpert or TB-LAM, but also chest X-ray. Also the strong point that TB treatment decision will not fully rely on lab tests or chest X-ray results. So when these tools are not available or results are negative, decisions still can be made, and there is a rapid treatment initiation for children with high risk, like children under 2, for example, children with undernutrition, that some specifically severe acute malnutrition, and children living with HIV. And also, of course, children in contact with TB and symptomatic will also start TB treatment quickly. So why this tool is so important? Because despite all the progress, recent progress in TB care, this childhood TB remains still underdiagnosed and undertreated, especially like in global TB report that we have recently received. We see a huge gap of TB diagnosis in children under 5, which was also already reported by our colleagues. This is the most affected group. So globally, we have 50% of children in this age group are not yet diagnosed. That means not started on treatment, and then the delays to the high morbidity and mortality. And that's why we have around 174,000 deaths in the children in 2024. And so why does it happen? Because there are some particularities of pediatric TB that diagnosis is very difficult in this group because of post-bacillarity of the disease. There are obvious challenges with sample collection, and symptoms, clinical symptoms are not specific among other factors which are contributing to these difficulties with diagnosis. That's why this TB treatment decision algorithm can address this gap by providing, as I already mentioned, quite universal, very structured and simple, and also rapid approach to the identifying the children and starting TB treatment. To implement the whole package of new pediatric TB recommendations, Doctors Without Borders launched a project which called TACTIC, this abbreviation for Test, Avoid, Cure TB in Children. The project was facilitating implementation of the whole package in 52 MSF projects among 12 countries. So the main idea was to support countries with practical use of these recommendations, but also important component was operational research to generate some evidence on effectiveness and feasibility, acceptability of these algorithms. And another important component is advocacy, of course, for the national policy reforms, adaptation of the recommendations at national TB program levels, and facilitating fast implementation and availability of resources. For the implementation of the algorithm, this pathway was chosen. So first, the study, TB AlgoPET study, which was conducted in five countries with different contexts. And the results of this study and also lessons learned were used for the further implementation, phased implementation in other contexts and projects. Of course, the results and lessons learned were adapted based on the context after the careful assessment, and also based on the reality of the situation, general health situation in the country, national guidelines, and available resources. So as I mentioned, the implementation was mostly phased, and then the main idea was integrate the algorithm into existing routine care for better sustainability of this tool of use. The most also very important point is the early stakeholder engagement. So MSF usually supports some health facilities at different levels in the countries, but in the TB care, not to disrupt existing system, patients can be diagnosed in MSF support facilities, but then they will be referred for treatment initiation and continuation and follow-up to the existing national TB program, TB clinics. And so that's why collaboration with the Ministry of Health, national TB programs, and other TB partners is very important. Another important was, of course, the most important probably was the collaboration with communities or community engagement, because early identification of TB symptoms should be done at the community level, and community should be very well aware where to go, how to proceed, and what is the TB and how it should be treated. And we realized in our experience that in many contexts, TB is still perceived as an adult TB, adult disease, not a child. So although the tool is very clinical, but implementation it's not just a clinical process. It requires a coordination and collaboration with the complete health system. So we also planned, like targeted, of course, capacity building for clinicians who will use this tool, and we also tried to establish the continuous mentorship through TB focal points, and to monitor the progress and also adjust in the process, try to use some simple monitoring indicators. So as a first step, as we already briefly discussed, the first step was to update the guidelines, and to step between updating guidelines and really implementing the tool in practice, there is a big, actually long process. So in MSF support facilities, we are using MSF guidelines. So first of all, it was aligned with the latest evidence-based practices. All recommendations were included in MSF guidelines. And then we also tried to support medical advocacy to promote updates of the national TB guidelines in countries where we are working. And in 2024, MSF conducted a survey on pediatric TB policies in 14 countries, and you can see illustration of the dashboard. And that a survey revealed still some significant gaps. In some countries, only a few recommendations were adopted. In some countries, very few countries really fully adopted all the recommendations. So continued advocacy was important. Then dedicated capacity is required to address well-known funding challenges that are happening right now, and to make the program more impactful and sustainable. And important was also to integrate the TB, to go beyond the TB services, because as our colleagues also presented, children with TB can be in different services. For us, it was important was, of course, nutrition and the maternal child health, primary health care. Briefly about TB AlgoPET study. So this study evaluated accuracy, feasibility, acceptability of TB treatment decision algorithms. The main results are presented in this slide. So the algorithms are highly sensitive and moderately specific, comparing to reference standard. And the important question was how much to, at what extent to expect the increase of the number of children requiring TB treatment after systematic use of the algorithm, because there was a concern that this tool will really increase the number of children requiring treatment, and maybe existing TB program will not be able to absorb all this treatment or to guarantee the treatment availability for these children. So an average algorithm doubled the number of diagnoses and treatments, but you can see on the on this illustration that depends on the context. It was between 1.5 up to 5 times increase. The most common reason to start TB treatment was clinical and radiological score, and algorithm was very well accepted by health workers, which is very important, and especially by caregivers also, because it provides easy and structured decision why this particular child needs a TB treatment. Also, as a result of the study, there were 10 key lessons formulated that we used for further implementation in other MSF projects. So when using these results of study, as we mentioned, we needed to adapt them to different contexts, and why it is important, we wanted to illustrate on this slide. There are some examples of different contexts that can affect the use of a tool. For example, in countries with high HIV prevalence, like Mozambique, for example, Guinea-Conakry, we can expect high HIV TB co-infection rate. It means to both services should be linked. Then the children living with HIV might have a higher risk of disseminated and severe TB or typical clinical and chest X-ray presentations. So some adaptations of the algorithm might be also considerate of other diagnostic tools, not only GeneXpert, but TB-LAM should be used as additional operational needs for the projects. And as I mentioned already, everything should be integrated in existing HIV services. Another example is countries with high undernutrition burden. For example, Nigeria, Niger, where there is a high prevalence of severe acute malnutrition, moderate acute malnutrition. And with this tool, there was a significant shift in the concept. So malnourished children, undernourished, basically were classified as having presumptive TB. So all of them would need evaluation with the algorithm. And children with malnutrition can have overlapping clinical signs, which are scored in the algorithm, like weight loss or signs of infections, fever. There is a shortened diagnostic pathway for child with some. That's why all of them will require GeneXpert or microbiological test submission. And it's very important to integrate both services, TB with nutrition, because all the children obviously require nutritional treatment together with TB management. And another example, for example, of complex humanitarian crisis, which we observe currently in Central African Republic, Democratic Republic of Congo, Somalia, or South Sudan. Although all of these countries are suffering of crisis, there is no universal approach. Each context, all of them are in crisis, but each has their own unique situations. So we can expect a high population displacement, as our colleague already presented, and that means will be difficulty with access, quite maybe fragile health systems, and poor continuity of care, because after diagnosing the TB, we should ensure the treatment access and follow up until the continuation. And there is competing seasonal health priorities. For example, malaria, measles, diarrhea outbreaks, which are related to the high admissions in the facilities, high work overload for the clinicians, and then sometimes in these critical situations, TB can be deprioritized. Another important component of algorithm is new, which is new, is also a chest X-ray. Unfortunately, for the moment, not everywhere chest X-ray is still available. Sometimes if it's available, the quality is far from good, and also we have to take into account high costs of chest X-ray equipment and maintenance, also additional staff costs for chest X-ray technicians. There is also sometimes a limited interpretation capacity of the chest X-ray images. So we know that in many contexts, radiology specialists might not be available. So we try to elaborate simple, very targeted chest X-ray training to catch the 5 main findings, which are presented in the algorithm scoring table. But also there was a need to do some mentorship to improve quality of the chest X-ray techniques. And then to enhancing the evaluation, the quality evaluation of the images, we have a telemedicine platform where clinicians can submit their images, and the specialists will support the interpretation. But also important was to recommend TB treatment decision algorithm B, which is without X-ray, even when X-ray is available, but quality is inadequate or very limited interpretation capacity exists. Also interesting, it was to relate point of care ultrasound, because actually ultrasound is much more available in the MSF projects, but this algorithm is not made for ultrasound findings, and some countries' national programs already implemented computer-aided detection software, like in Central African Republic, for example. But unfortunately, there are still limitations with its use, because currently it's not yet recommended for children and adolescents under 15. This was some operational observation. There are still open clinical questions on tool itself. Maybe briefly, there is no yet clear guidance of timing when to use the algorithm in clinical scenarios. So, for example, nutrition ward on admission to nutrition ward or during the follow-up. So there is no clear time frame for different clinical situations. As we already observed, there might be some symptom overlap or clinical evolution in some conditions. So how to interpret children, TDA in children where they already improve meanwhile on nutritional treatment or IRT therapy? Should TB still considered despite this minor improvement? As I mentioned before, it's interesting also to try to also connect it with focus point of care ultrasound, although today it was not designed for ultrasound findings, but some situations were observed, maybe subtle findings like minor pleural effusion are not visible on chest X-ray, but can be easily catched with ultrasound, but unfortunately cannot be really scored. So extrapulmonary TB is another big challenging field in low resource settings where we are working. There is very limited capacity to diagnose and manage the extrapulmonary forms, and there is a need of specific guidance or another parallel algorithms for this group of children. Sample collection in the algorithm, there is just a referral to collect a respiratory specimen without specification, and the current recommendation also includes several samples to increase the diagnostic yield, for example, which was not reflected in the collection, but it's also additional resources and reporting and documentation, because still TDA is not included in NTP reporting tools. So there is a limit to monitor its systematic use and quality of its use impact. So what were the challenges observed during the implementation? The first, we realized that updating guidelines is not automatically, it means implementation and particular facility levels. In many contexts where algorithms were fully integrated in the national guidelines, but there were incomplete country rollout, for example. So in this situation, systematic use of the algorithm is very challenging, because there might be, for example, referral issues. Some children might be referred out to another facilities where TDA was not yet introduced, or even clinicians are not aware, so they might not accept children diagnosed with this tool. And then we also observed that some countries were hesitated to update the national guidelines due to anticipated this rollout challenges. Then the second question was that this tool aimed to increase TB diagnosis and treatment, but how much and what magnitude, and will the national programs be able to absorb these children? So as we saw, studies showed the average 2 times increase, but in some context where there was previously around 5 children diagnosed, under 5, for example, diagnosed per month, so 2 times increase, it means 10 children per month. That is easy to absorb, to also secure the treatment for 10 children. But in high burden malnutrition context, for example, we observed from 20 to 50 children per month, which is already a significant increase. And also, it's also a significant burden workload to the TB services, not only for treatment availability, but also follow-up, workload, reporting, etc. So that's why to implement the algorithm is important to provide, to perform a careful planning, so with good collaboration with partners, ensure drug supplies and staff training. So at the conclusion, we would like just to confirm and to share that, yes, TDA provides a structured and evidence-based approach, pediatric TB treatment decision in children with pulmonary tuberculosis, and it's highly sensitive to detect TB, and implementation is feasible and well accepted both by healthcare providers and also caretakers. So TB treatment decision algorithms improves early identification and very quick treatment initiation, especially for high-risk children under 2 living with HIV and with severe acute malnutrition. But for successful implementation, we need to policy adoption, guideline updates, and also universal rollout in health facilities. Capacity building and mentorships. Mentorship is very important. Collaboration with the MOH and partners was also one of the important steps, but community engagement also is one of the clue components to ensure the implementation. There are some still remaining operational challenges. Like we all know the problems with shortage of funding and drug supply, not maybe availability of drugs, but sometimes in some contexts, the transportation can be a problem. There is a increased workload and some diagnostic limitations. Not everywhere gene expert and chest X-ray are available. Also, the algorithm doesn't require full availability of this. And then continued research, adaptation, and advocacy are really essential for this sustainable and effective use of this important tool. Thank you very much. This was all our presentation, and here you can find, if you're interested, more information about Bakyt project and Epicenter page about the different study results. Thank you.
Yeah, thank you very much, Olga, for sharing the experience on the treatment decision algorithm. So, and thank you very much to all the presenters. So now the floor is open for questions. So, but maybe before we go further, so there are some questions on the Q&A. Maybe we can start with those questions. And the question goes to Bakyt. So how does the funding landscape change affect your implementation now? Do you lose some of the partners and the stakeholders? Bakyt, this is a question to you.
Yes, especially the situation in all of the world is also affected not only for KS partners, not only for KNCV, also other partners. For now, at the last few years in Kyrgyzstan, stopped working in, especially in TB field, International Red Cross Organization, also MSF stopped working with tuberculosis. Also significant reduction of Cure TB project. Also, so it's in case of partners, implementing partners, significant reduction of funding. It's but at the same time we have a situation when at the country level, in accordance with the agreement with the Global Fund, every year government trying to increase budget for and funding for tuberculosis, and at the last few years significant amounts was shared with the TB program, and especially with the less number of detected TB cases, especially we not especially spend all available funds. We start a national tuberculosis program procuring first-line drugs, part of the second-line drugs, started procuring some reagents and supply for laboratory, also including genome sequencing, and huge impact from domestic funding, and we have to say that but at the same time international funding is decreased.
Yeah. Okay, Bakyt, thanks for that. So still, I think the next question also is you, Bakyt, and this is a question from Agnes. Oops, sorry. Yes. Ken said, okay, dear Bakyt, thank you for the great work and the presentation. I would like to ask you, how are the NTP and stakeholders monitoring the implementation of the improvement plan? Is there any follow-up plan?
Yes, for now, just 1 month ago, we complete this work and prepare report. And we agreed that every quarter, it will be some kind of regular quarterly meeting when we have to update about the progress of it's like a basic roadmap of these activities, what exactly we have to do on urgent in the current 2025, beginning of 2026. And every quarter we agree that sit together with partners and review progress of implementation, what exactly done and what not yet done. And especially maybe one of the partners, maybe Cure TB or Global Fund, UNDP, maybe can pick up support of this kind of quarterly meeting, because we complete our project, just provide this kind of analysis in collaboration with the NTP, but for further developments, we look for the partners' availability to support this kind of meeting and review progress about this roadmap.
Okay, thank you, Bakyt. So any question from the audience, you can raise your hand if you have any questions. So there is also another question in the Q&A, but this question is not directed to anyone. Larry, if you are still here, can you raise your hand and maybe ask your question and direct it to one of the presenters? Yes.
Hi, thank you very much. I would love to hear more perhaps from the last speaker, to what extent and if any, through which mechanisms were adolescents meaningfully engaged in the design and implementation of the project, perhaps like their potential role in advocacy, in peer outreach, or is there any other challenges that actually came from the adolescents themselves? Thanks.
Yeah, thank you. That question goes to Olga.
Yes, thank you, Larry, for the question. As I presented, the TB treatment decision algorithms, they are meant only for children under 10, so with the symptoms of pulmonary TB. So algorithms are not useful for adolescents, unfortunately. So that's why, but in this particular group, we don't have activities related to adolescents. But of course, still adolescents are also underdiagnosed everywhere, and when maybe other components of the recommendations that are prevention, TB prevention therapy, or new shorter treatment regimen of 4 months for children with DSTP are highly also applicable for this age group. Maybe more details we can discuss later, but in general, for the community engagement that I mentioned, of course, we try to adapt the community engagement to existing contexts. So we realize that in some contexts, for example, in Somalia, there were the male leaders of the family are main decision makers for the children to go to search for care, and sometimes it can be older adolescents, also older brother, who will finally decide, yes, this child is sick and he needs to go to the hospital. And the health education, also collaboration with adolescents and this extent were very important. For other contexts, maybe nothing right now comes to my mind, but thanks. I will maybe think a little bit about and share.
Yeah, okay, Olga, thank you very much. So I did not see any other hands, and we are almost at the time. So yeah, but maybe we can take one more questions, which I will like to give to myself as an opportunity. So, and my question is also to you, Olga. Yeah, understanding that the TB symptoms and other symptoms of childhood illnesses can be resembled to each other, and in areas which you know that you have seasonal diseases like malaria or any other conditions. Don't you think that maybe during that time there might be a possibility of overdiagnosis when using the treatment decision algorithms on conditions which you know that they have symptoms which are resembled to each other? Like, for example, when you talk about in high burden areas where you know that, okay, the number of cases goes from 20 to 50.
Yes, Mansa, thank you for this question. I think this is a question also similar in the chat from Eshetu Abdisa, so also concerns about overdiagnosis in the TB treatment decision algorithms. Yes, it was one of the main fear that we saw, that we observed when we were practically discussing the algorithms with clinicians, and there were many also challenges, because everyone was exactly thinking that if we apply algorithms, so most of the children will start, basically all children who were evaluated will start TB treatments. But in reality, it was not a case, and you can see the results. For example, the more like visible that we can offer as a result of this TB AlgoPet study. So there were around 1,800 children enrolled to the evaluated with algorithms, and only 500 started the TB treatment based on clinical radiological score or TB contact. So the algorithms are maybe sensitive to find the children, because our main aim is to find these underdiagnosed children, but there are a little bit of concerns of specificity. But in high context, in high burden TB burden contexts, over treatment can be acceptable, because with this algorithm we will find children that we really were not able to find with previous tools. But of course, some of children will be overdiagnosed and overtreated. But we all know that children tolerate TB treatment well and have less side effects than adults. So that may overweight all the related risks. And in that you mentioned, like during the peaks of malaria, for example, and diarrhea, or measles that we observed. So maybe the key was the duration of the symptoms, because algorithm only gives score if the symptoms persist more than 2 weeks. So hardly any malaria in child, especially under 5, will have a fever more than 2 weeks without any treatment. So it's very rare. Usually it's very acute presentation, and so that's why in reality we didn't really observe that many other infections were falsely classified as TB and started as treatment.
Yeah, okay, Olga, thank you very much. So, and yeah, I will say that thank you everyone for joining this webinar, so which is the concluding webinar for the year 2025, and we are looking forward to see how we can continue in 2026. So I say thank you to all the presenters and the interpreters also who are supporting us in the different languages. And also thank you, Juan, for supporting all the technical support from your side. Yeah, thank you very much, and wishing you a very nice coming holiday soon, and a happy 2026.